Septic Shock PowerPoint 2025 by Olivia, Delaney, Robert, Adrian, and Sawyer. Paramedics fit into a difficult position within the hospital system because they are in a place to recognize early signs of our most challenging enemy, shock. In this article, the studying paramedic will explain only one of many forms of shock they will deal with within the field, with the focus being pathophysiology, presentation, treatment, and pre-hospital transport considerations. Now imagine your body is the city of Venice, and the water pathways become the blood vessels, that the energy and oxygen are transported onto all the stops, or cells, in the human body. In septic shock, the body has an inflammation that is making these pathways inefficient, ineffective, and potentially life-threatening. How can we as paramedics keep this city safe? Now, what is septic shock? Septic shock is the last stage of sepsis where your blood pressure drops from vasodilation to a dangerously low level following an infection. It is the most severe stage of sepsis. It occurs when the body's immune system overreacts to an infection, leading to a widespread inflammation, tissue damage, and organ dysfunction. If untreated right away, septic shock causes dangerously low blood pressure, organ failure, and death. Sepsis starts with systemic inflammatory response syndrome, or SIRS. SIRS is a series of identifying qualities beginning with a body temperature of above 100.4 degrees Fahrenheit, or 38 degrees Celsius, and below 96.8 degrees Fahrenheit, 36 degrees Celsius. Heart rate will present a greater than 90 beats per minute, respiratory rate of greater than 20 breaths per minute, PaCO2 less than 32 milligrams of mercury will be the last important identification marker for developing stages of sepsis. Recognizing that these signs exist along a spectrum gives us some skill in identifying how far along into the process the patient is. And it ends with the multi-organ dysfunction syndrome called MODS.
In this slide, we're talking about clinical differentiation. So, how does septic shock present differently from hypovolemic shock or cardiogenic shock, and what are the underlying causes for each kind of shock? As you can see here, hypovolemic shock is mostly related to fluid loss, and in our field, we'll likely see that in cool or pale skin, things like that. In cardiogenic shock, we'll see pump failure, which usually stems from pulmonary edema, things like that. You'll see swelling in the ankles, swelling in the extremities. And in septic shock, which is more of a distributive shock, and being infection-driven, we'll see a lot of vasodilation, or that warm skin or mottling in cool skin when you have late stages of septic shock and forms of hypoperfusion.
Now let's get into the pathophysiology of shock.
Sepsis begins with a bacteria, fungus, or virus that triggers the immune system to produce and release inflammatory mediators like chemokines, cytokines, and prostaglandins. These cause neutrophil endothelial cell adhesion, which activates the clotting mechanisms in the human body. These inflammatory mediators cause the blood vessels to dilate, which then reduces the blood pressure, and the arteries and arterioles dilate, resulting in a decreased peripheral arterial resistance and an increased cardiac output. As this process continues, we start to see signs of hypoperfusion, and the cardiac output has now decreased and the blood pressure begins to fall. The inflammatory response damages the walls of the capillaries, making them leaky, which causes the fluid to escape into the surrounding tissues, which is when we would see edema. Blood flow is bypassed to the capillary exchange vessels due to the vasoactive mediators. So shunting and capillary obstruction has a very wide-ranging systemic effect, which includes the poor capillary flow, which decreases the delivery of oxygen, and the difficulty removing waste and carbon dioxide. And with the increasing carbon dioxide in the blood, we then see a wide-ranging increase in the acid levels in the blood. This increasing acid levels stems from our mitochondria being forced into anaerobic metabolism, which produces excess levels of carbon dioxide in the blood. Our sodium bicarbonate system is sensitive enough to pick up these signs and changes in the acid levels of the blood, and then begins to compensate by increasing our respiratory rate, dropping our blood pressure due to vasodilation, and increasing our temperature. These can all cause systemic dysfunction and then ultimately lead to organ failure, and if it's not treated promptly, organ failure will then lead to death.
Now we will move on to how septic shock presents. According to Cleveland Clinic Journal of Medicine, 15% of patients suffering from sepsis will go into septic shock. These are some early signs and symptoms to watch out for to ensure your patient either doesn't go into septic shock or does not stay there long. Hyperthermia or a fever can be a sign of septic shock, as well as hypothermia or cooler temperatures in patients that are immunocompromised or the elderly. Altered mental status, including lethargy, confusion, and agitation, can also be strong indicators of septic shock. A weak, rapid pulse or tachycardia, as well as faster respirations called tachypnea, can also be seen. Similarly to tachycardia, tachypnea is typically accompanied by very shallow respirations with increased work needed for those respirations. Now let's dive into some signs and symptoms that can indicate later stages of septic shock. The first set of symptoms we will cover can indicate to the provider that the patient is suffering from hypoperfusion. Oliguria, or decreased urine output, delayed capillary refill, which can be seen by pushing on the patient's nail beds and timing how long it takes for the red to come back. Mottling, which is blotchy rashes on the skin. Poor peripheral pulses, which can be demonstrated in struggling to find radial and pedal pulses in the patient, as well as cool, clammy skin, can all indicate hypoperfusion or a lack of oxygen-rich blood being delivered to extremities or organ systems throughout the body. One of the biggest indicators of septic shock in early and late stages is that altered mental status we covered a little bit ago. In later stages of septic shock, it gets far more intense, and the patient can even go unresponsive, which can make it very challenging to get sample OPQ or ST. Now, I will briefly talk about signs and symptoms in a clinical setting. Nurses and doctors test for lactate, creatine, and bilirubin to determine which systems in the body have been affected by septic shock. High levels of lactate indicate the body is going through anaerobic metabolism, which means that it is not using oxygen to gain energy. As Delaney mentioned in the slide before this can indicate the bicarbonate system is all out of whack and multiple body systems are trying to help compensate for one another. Increased creatine can indicate renal failure, and increased bilirubin can indicate liver damage. Let's talk about some susceptible patient populations. These populations are at a greater risk for septic shock, and here is why. Foley and suprapubic catheters are highways for germs and bacteria into the human body. Those with chronic medical conditions like diabetes, heart failure, or kidney disease are constantly putting their body through the ringer, fighting their disease or their ailment. This can weaken their immune system or them as a person overall and make it challenging to fight infections. Immunocompromised or suppressed patients are also at a greater risk because of the damage or incapable immune systems. Cancer patients, transplant recipients, and pregnant and postpartum women are all under this category. Age is also something to look at when trying to determine if someone is suffering from septic shock. Very old and very young populations are at a greater risk because of their underdeveloped or battered and bruised immune systems. This is one of the many reasons that in your initial assessment of your patient, sample and OPQ-RST are very important. While certain ailments are easy to see, some will need to be disclosed to you in order to consider them in your differential diagnosis.
As an EMS provider, we need to be good at figuring out what is going on with the patient. This starts with a good assessment. A good assessment is key to identifying what is going on with the patient, whether the patient is sick or has a traumatic injury or has a major infection that is causing septic shock. Early detection of septic shock can improve and will improve the outcome of the patient. Early detection will reduce the mortality rate of patients. If we can identify that the patient is in septic shock, we can start treating them. We are treating the symptoms at this point because what they really need is antibiotics. The first thing as emergency providers, we can start with oxygen because their oxygen level in the blood is low. We can put them on nasal cannula or an on breather and try and bring that oxygen level up to help with perfusion and the metabolism of the cells. We can also treat the patient with IV fluids to attempt to bring the blood pressure up. Since in shock, the patient will have a lowered blood pressure. We want to give them fluids to try and adjust the blood pressure to a better level that we are more comfortable with. Fluids should be given in an amount in response to the patient. Patient is responding really good to the fluids, we keep going. If they're not responding the way we want them to, we can slow down the amount of fluids that we are giving them at that point. Fluids are slow at reacting and resolving the blood pressure issue. We can also give them vasopressors in order to try and achieve the best blood pressure for the patient. But in the end, the patient really needs antibiotics and close monitoring at a hospital and a facility that is able to do all the blood tests and keep close eye on the patient. Blood tests will help identify type of disease going on, and they can give an antibiotic that is better suited for that disease versus just a broad spectrum antibiotic. So as EMS providers, the best treatment for any patient with septic shock is early identification that this is what is going on. And then we can manage these symptoms with oxygen, fluids, and vasopressors to keep them from getting any worse while we get them to a hospital that can give them all the antibiotics and the care that they need.
To finish our presentation, we thought we'd round everything out with a critical thinking question that ties back into the PowerPoint itself. This question would be, why might lactate levels be elevated in a patient with late-stage sepsis or in septic shock? We have a three-part answer. In this, anaerobic metabolism, due to poor perfusion, increases CO2 levels within the human body. Because of this, what it represents as an increased lactate, which is a marker of hypoperfusion. This is an important identifying factor because the body is compensating for acidosis by breathing faster with increased respiration rates, thus reducing CO2 levels, which in turn reduces the end-tidal CO2. In this, we have an activation of the bicarbonate/CO2 buffer system. Because septic shock progresses at such a rapid rate, identifying what stage and interventions are needed is crucial in improving reducing the mortality rates for individuals. We can do this by identifying which symptoms are most pertinent. Symptoms like hypotension, altered mental status, poor peripheral pulses, and fever indicate a severe case of septic shock. Septic shock itself is often caused by an untreated infection, and treating that underlying cause can improve the patient's health and symptoms. Public education, further research, and in-depth knowledge of providers can all contribute to helping and healing those suffering from septic shock, and even reduce cases of septic shock in our communities. Stopping septic shock before it starts provides everyone with the best outcome. Now that we have read through the PowerPoint, we decided to create a short scenario that ties together all of the points and parts and pieces, identifying features, presentation, vital signs, and other types of pre-hospital treatment that paramedics might need to think about or consider when coming in on a patient that is in a late stage septic shock. We have been dispatched at 3 o'clock to a private residence in a rural setting. The dispatch on the IAR states that we have a 65-year-old female, fever, altered mental status, and trouble breathing. My partner and I respond to the scene. We arrive to a dimly lit home. There's a family member standing on the front porch waving us inside. The family member says,
"She's been sick for a week. She's on chemotherapy for lymphoma. She got worse tonight though. She has a fever, she's shaking, and she's barely responsive."
As we enter the scene, we see what appears to be a 65-year-old female. We notice the environment is that we have a hot room, patient is in bed with blankets, and is visibly sweaty. So my partner Delaney here, she begins her initial impression of the patient.
I'm going to take the blankets off.
Okay.
Hi, ma'am.
She finds that the patient is lying supine with eyes half open and only responding to painful stimuli. As Delaney continues her impressions, she pulls back the patient's sweater and notices that the skin is mottled, clammy, but also flushed in some areas. And she notices that there's some cyanosis on her lips and around the nail beds. As she continues her assessment of the patient, she notices that the patient is breathing rapidly and shallow. And there's a strong odor of urine in the room. My partner Delaney then asks me to start a set of vitals. So she takes a pulse rate. She finds that the pulse is 138 beats per minute, weak and thready. She finds that a blood pressure is 82/46. She notices again that the respirations are 32 per minute, shallow and labored. She finds an SpO2 of 88% on room air. She then tests the patient's temperature because of how hot her skin is and finds that it's 103.1 degrees Fahrenheit. Then finally, for altered mental status, she checks the blood glucose and finds it at 96. She field weighs the patient at about 120 pounds. As she's assessing the airway, she finds that it's patent and the patient has a weak gag reflex. With the patient being in altered mental status, it necessitates that we communicate with the on-scene family member for a sample and OPQRST history. So we begin with signs and symptoms. We find that the patient is nonverbal. The family member says,
"She's been sick for days. She's hot to the touch. She hasn't been able to eat much."
and you continue your assessment.
Does she have any allergies?
Yeah, I think so. Penicillin and aspirin, I know that.
What is her medical history right now?
She's just pretty much just undergoing chemotherapy for lymphoma.
Okay. Does she have any history of hypertension?
Yeah, she does.
Okay. With that low blood pressure, that makes me nervous about having a history of hypertension and presenting with low blood pressure. Other than the cancer treatments, has she had any recent hospital admissions?
Just for a fever, that's about it.
Okay, so she has been in here recently. When was the last time she ate anything?
She ate a small meal yesterday. That's about it.
Okay, was she able to keep that down?
Yeah.
Okay. Then, besides the fever, has she had any signs of weakness or dizziness?
Yes. Weakness for sure.
Okay. And then has she been vomiting or any diarrhea at all?
Diarrhea. It's been getting pretty bad over these past couple days.
Okay. That might also show with that hypovolemia.
Mm-hmm.
So at this point, I'm going to consider what I'm able to do as a BLS provider and administer high flow oxygen. And given that altered mental status, we're also going to look at an airway air adjunct if she accepts it or is tolerated. So we place the patient on high flow oxygen. We again, after that intervention, to assess the patient's, we place some supine, monitor the pulse and the skin. We do another blood pressure on the other arm, alternating to see how the patient responds, any changes in blood pressure, and then we do frequent reassessments.
Mm-hmm.
As ALS providers, what would we consider then?
We would start an IV
Okay.
to start fluid resuscitation and possible use of vasopressors like norepi or dopamine.
Okay, that makes sense. Then for shock management purposes, we're going to make sure to keep the patient warm and consider rapid transport. And in that rapid transport, we want to communicate to the nurses there at the hospital or the receiving party at the hospital that we need to likely get this patient on some sort of IV antibiotics. That hour of time after we identify the possible symptoms that she's dealing with, the possible septic shock, is when we want to communicate that. So, at what point in this assessment did you feel like this patient might be going towards septic shock?
During initial appearance of the patient and then the vital signs going along with it, the low blood pressure, the fever, the tachypnea, tachycardia.
Okay. So all of those things would continue to contribute towards that level of septic shock?
Yeah.
Okay. Why is it important for early recognition and hospital notification? So we do that because in this situation, time is tissue. Every single hour that this patient is without antibiotics, it increases their chance at mortality and certainly organ failure. So early recognition is definitely key. And again, with this patient specifically, she's on chemotherapy, so that overall reduces her white blood count, which blunts that immune response. So in septic shock, infection progresses rapidly. And then again, to Delaney's point, high heart rate, low blood pressure, fever, altered loss of level of consciousness, and then that temperature are all significant red flags for exactly septic shock.
So what is the pathophysiology of what makes you think this is septic shock?
So given our good patient assessment and medical history that we did on the patient, I'm under the assumption that she's in some sort of systemic infection. This systemic infection is causing her overall blood vessels to vasodilate, which is accounting for that low blood pressure. Considering that she has hypertension in those things, to see those numbers, it makes me nervous as a provider. So I want to make sure that I build that system as much as I'm able, which is why we would consider those IV resuscitation protocols. In that, we have to be careful because what's occurring is there's capillary leak in this patient themselves with that systemic vasodilation, and so the more fluids we push into that system and the vasopressors that we use, we have to be careful because it can increase the overall edema of that patient. In that, it can lead to distributed shock, more of the things that we've talked about with shock symptoms in general, but it's very important that we understand that poor perfusion, increased acidosis of the body, that again back to that mitochondrial anaerobic metabolism that we deal with, all of those things in that sodium bicarbonate system that our body's incredibly sensitive to, all of these things are being thrown off by that systemic inflammation that she's in. With that, there's obviously limitations to BLS interventions. Why we need to learn medic level things, it gives us that opportunity to really make a reasonable and marginable impact on this patient faster and on scene. And by the time that we get to the hospital, we've at least attenuated some of the problems that we can help with. And again, early recognition, good patient assessment, and good communication with the local hospital about what this patient might be experiencing will be very valuable at the time that this tissue